Hi, everyone. Thanks for joining. Um, we're due to start at noon here Eastern time in the US, so we'll give everybody a few more minutes to join and other people from Moichor to join as well, uh, and then we'll begin. Thanks for joining, everyone. I think we'll give people another minute or two, and then we'll kick things off.
All right, so we're gonna go ahead and get started. Okay, good morning or good afternoon, everybody. Thank you so much for joining our webinar this month. My name is Kaori Davis. I am the Chief Medical Officer at Moichor, and today we're going to talk about lymphoma. And this is going to be a joint webinar between me and then our Chief Technology Officer, Dr. Liam Cattell. So during my part of this webinar, we're going to review lymphoma, and we're going to put an emphasis on the classification of lymphoma and then also the key features of all these subtypes. And then we will discuss a little bit about the species differences in dogs and cats. And we will go over the diagnostic tools that we have. And we have a really exciting new offering, which is the PathView AI-powered lymph node assessment. So we're going to go over that briefly, and I will hand it over to Dr. Patel. All right, so let's start with the lymphoma review. Lymphoma is a neoplasia that arises in lymph tissue or lymphoid tissue that is located outside of the bone marrow. We have lymphoid tissues throughout our bodies. The most obvious ones are the lymph nodes, but we also have spleen, which acts as a lymphoid tissue. And also we have multiple mucosal associated lymphoid tissues, such as the tonsils or Peyer's patches. The figures at the bottom, if you can see them. So the figure on your left, we have this aggregates of lymphocytes, and then we can even appreciate some of these structures like their germinal center and then like nice follicular structure, which is located underneath the intestinal epithelium. This is the Peyer's patch. And we also have the tonsils, which acts like an entry point of a lot of things that we inhale, basically. Lymphoma is a clonal and a malignant proliferation of a single lymphocyte that underwent neoplastic transformation. And we use the term lymphoma, but this is actually an umbrella term for this remarkably heterogeneous group of diseases. And we have so many different subtypes that we have recognized. And these subtypes have really variable biological behavior, ranging from slow progression, indolent disease process to a very aggressive and rapidly progressive disease. In humans, there are more than 60 subtypes that have been recognized, depending on which classification scheme that we use. The lymphoma can be either nodal or extranodal, meaning it can arise within the lymph node, but it can also be anywhere in the body, pretty much. It can be on the skin, it can be in the nose, or it can be in the kidney, it can be mediastinal, and sometimes we can even have lymphomas within the central nervous system. So let's dive deeper into this lymphoma classification. There are so many tools that we can use and so many aspects of lymphoma classifications. We often use immunophenotyping, which will differentiate T cell versus B cell. The cell morphology is another important factor when it comes to differentiating the subtypes of lymphoma. Some lymphomas will have immunoblastic appearing neoplastic cells versus others will have centroblastic lymphocytes. Cell size is another common one. Some lymphomas consist of small lymphocytes, some are intermediate, and some are large. And grades are also important. We can divide the lymphocyte subtypes into low, intermediate, or high grade. And then there are also histological patterns within the lymphoid organs and also the anatomic locations in the body, such as mediastinal lymphoma or nasal lymphoma, renal lymphoma, etc. And we're going to review all these different classification methods later in this talk. So in veterinary medicine, we have about 40 different subtypes of lymphoma that we've been using and we have recognized. And the common classification scheme that we use when we classify the lymphoma is the REAL or Revised European American Lymphoma Classification System or WHO system. These classification system, though, it is important to remember that this requires histopathology for us to accurately differentiate these subtypes. So Let's look at the histological patterns. We can look at exactly where within the lymph node the neoplasia started, and then that will have different indications. The prognosis may be different, and also the cell type may be different. So here is the schematic drawing of the lymph node. The lymph node has the capsule on the surface, and then it is subdivided into little compartments by the sinuses. And on the surface, we have the cortex here, which will have a lot of B cells that live here. And then in the middle, there is a paracortex where the T cells live. And then in the very center of the lymph node, there is medulla. And again, depending on where exactly within the lymph node the neoplastic cells are originated from, the behavior and in the cell type and in the prognosis may be vastly different. We can also look at the tissue architecture of the lymphoma. Sometimes the lymphoma can show different patterns of expansion and an invasion, and the tissue architecture that can tell us the behavior of the lymphoma. So here on the far left, we have the normal lymph node, and we can appreciate the different compartments, the different structures. We have nice follicles here and there, the paracortex here, and then the medulla in the middle. And the second one from the left, this is a lymphoma that is showing the diffuse pattern. If you can compare this figure to the normal lymph node, you can see that the normal architecture of the lymph node is completely effaced, and then the neoplastic cells diffusely just took over the entire lymph node. Sometimes the lymphoma can show nodular expansion pattern. So in this figure here, you can see the neoplastic cells expanding. These pale blue cells are the neoplastic cells, and then instead of taking over the entire lymph node, these neoplastic cells are showing this chunky and a nodular pattern of expansion. Some lymphomas have really unique and characteristic expansion and tissue architecture pattern, which is the epitheliotropic. So in the epitheliotropic lymphomas, the neoplastic lymphocytes have the affinity towards the epithelium. So they will have this linear expansion pattern right beneath either the skin or the mucosal epithelium. And instead of expanding first within the lymph nodes, they will have this widespread and linear expansion near the cutaneous or the mucosal surface. High and low grade lymphoma. So the grading is another really important classification that we use. And basically, the low grade versus high grade lymphoma differentiates the rapidly growing versus the slow growing lymphomas. So the high grade lymphomas are aggressive and then rapidly growing. So the cells within the high grade lymphomas are more frequently dividing in an active mitotic status. So the high-grade lymphomas will have higher mitotic index, and then they have greater than 20 mitosis in 10 hyperfield in the histopathology. But often this mitotic index can be 50 or greater. The mitosis can be really atypical, so we see bizarre mitotic figures in these high-grade lymphomas. And compared to that, the low-grade lymphomas are slow-growing, and then the cells are not as frequently dividing. So we typically see less than 5 mitotic figures in the 10 hyperfield. The neoplastic cells in high-grade lymphomas, they tend to be intermediate to large, but oftentimes large in size, versus the low-grade lymphomas typically have small, mature lymphocytes that are about the size of red blood cells. High-grade lymphomas like to exhibit cytological atypia. So the cell or nucleus size can be irregular, and the chromatin is open and delicate because these cells are rapidly and actively dividing. and they often have prominent nucleoli. But those are not as common in low-grade lymphomas. The low-grade lymphomas usually have round and then kind of like unremarkable shape of the cells. The chromatin is usually dense, and then nucleoli are not really prominent. High-grade lymphomas are really aggressive and invasive. So they oftentimes have this diffuse pattern within the tissue expansion pattern. And the low-grade lymphomas, they are less aggressive and then a little more considerate to the neighboring cells or neighbors' property. So they often expanded and push the normal architecture of the lymph node, but they oftentimes still have the remaining normal structures that are just pushed to the periphery. P67 is a marker that we can use to see exactly how many cells are basically dividing. This proliferation index is positive in oftentimes 60% of the neoplastic cells in high-grade lymphoma, but it is only positive in 10 to 20% or less in low-grade lymphoma. In dogs, some of the common subtypes of high-grade lymphomas are diffuse large B-cell lymphoma and in peripheral T-cell lymphoma, and also the lymphoblastic lymphomas. And some of the common low-grade lymphomas are T-zone lymphoma, marginal zone lymphoma, and then also the small cell lymphoma. In cats, some of the common high-grade lymphomas include large cell GI lymphoma and also the mediastinal lymphoma. And the common low-grade lymphomas are small cell GI lymphomas and also nasal or renal small cell lymphomas. As you can imagine, the high-grade lymphomas are aggressive, so they show rapid growth, and then the patients with high-grade lymphomas tend to have shorter survival. And if untreated, the survival time is usually between weeks to months. But low-grade lymphomas show slow growth, and the patients often have longer survival, and then it can range from months to even years. Low-grade and then high-grade lymphomas can also appear very differently on histopathology and cytology. The top three figures, these are the high-grade lymphomas, and then the bottom three figures, these are the low-grade lymphomas. On your left, we have the low magnification histo images. The image on top, this is the high-grade lymphoma, again, showing this diffuse expansion pattern. So we cannot really appreciate the normal architecture of the lymph node anymore. It's just the sheets of neoplastic lymphocytes with sad, thin capsule remaining. The bottom image, this is the low-grade lymphoma. And then here, the pink part is basically the neoplastic cells that are expanding. But we can also see some follicles that are squished to the periphery of the lymph nodes. So we still have some remaining normal structure of the lymph nodes. They are just pushed to the periphery of the lymph node. The middle figures, these are the higher magnification of the histo pathology. Cells of high-grade lymphomas tend to be large, so they are larger than the red blood cells, and then their nuclear size can reach up to twice the size of red blood cells or more. The chromatin is delicate, so the nucleus stains paler, and then you can see nucleoli every now and then. And then here, there is one mitotic figure right here. And then also there are some remaining small mature lymphocytes. So there's one here, there's one here. And compared to these remaining mature small lymphocytes, basically all the other cells are much, much larger. And the bottom middle figure, this is the low-grade lymphoma. And here, the neoplastic cells are, compared to this red blood cell here, the size of the neoplastic cells is pretty similar. So these lymphocytes are not large. They are small to maybe intermediate in size. The chromatin is coarse, so their nucleus stains darker. And we don't really see prominent nucleoli in these neoplastic cells. And the figures on the right, this is the cytology. So on top, we have the high-grade lymphomas showing just numerous really large immature lymphocytes. And here we have one sad mature lymphocyte here. And compared to this lymphocyte, everybody else is much, much bigger. And then the chromatin is more delicate. So the nucleus is much paler. And we have one mitotic figure right here. As opposed to this high-grade lymphoma appearance, cytology of the low-grade lymphoma can be really challenging. So this is the low-grade lymphoma cytology. And the mature small lymphocytes are circled in blue in this figure. But if you compare these cells to the remaining of the cells, the size is pretty similar. And then basically the appearance is really similar. So small, low-grade lymphoma or small cell lymphomas tend to be really challenging to diagnose based on cytology alone. Immunophenotyping is another common thing that we do in veterinary medicine. So basically, we will differentiate B-cell lymphoma versus T-cell lymphoma. And many of you probably remember learning at vet school, B is bad and T is terrible. So B-cell lymphomas tend to have better median survival. And then T-cell lymphomas often have worse prognosis, but of course there are exceptions to that. So some T-cell lymphoma subtypes have longer survival time compared to some of the B-cell lymphomas. And again, Ki67 is another marker that we can use to differentiate proliferating versus not proliferating cells in high-grade lymphomas usually show 60% or greater positivity of the Ki67. So now let's talk about the species difference. In dogs, about 85% of the lymphomas can be classified into top 5 subtypes. The most common subtype of lymphoma in dogs is diffuse large B-cell lymphoma. This is about half the canine lymphomas, and this is a high-grade and rapidly progressive disease. Peripheral T-cell lymphoma, not otherwise specified. This is a group of T-cell lymphomas that we cannot subtype any further. And this is about 15% of the canine lymphomas, and this also has poor prognosis. T-zone lymphoma comprises up to 5 to 10% of canine lymphomas, and this is an indolent lymphoma. Marginal zone lymphoma is another indolent lymphoma, and it takes up about 5 to 10% of canine lymphomas. And we also have T lymphoblastic lymphoma, which is about 4%. In dogs, about 60 to 70% of lymphomas are B-cell origin, and then 30 to 40% of lymphomas are T-cell origin. And based on these statistical data that we can have educated guess when it comes to the canine lymphoma cases. If you have a lymphoma in a dog with large neoplastic cells that are B-cell in origin, it is most likely going to be diffuse large B-cell lymphoma. And also, vast majority of canine large B-cell lymphomas will be multicentric. So they oftentimes present with multiple lymph nodes that are enlarged. Cats do lymphomas really differently. And in cats, the GI lymphoma is most common, and about half of the lymphoma cases in cats are within the GI tract. And interestingly, the lymphoma types and then also the behavior can be really different depending on where in the GI tract the lymphoma arises. So the gastric lymphoma, for example, in cats can be very different from the jejunal lymphoma. Historically, the FELV-induced T-cell mediastinal lymphomas were very common. And also, nasal B-cell lymphoma is another common one in cats. But nowadays, most cats are FELV negative. So these days, the FELV negative B-cell intestinal lymphoma is more common than the FELV-associated lymphomas. So to diagnose lymphoma, we use cytology and then histopathology most commonly. And lymphoma is one of the diseases where cytology can shine. And cytology can often give you the definitive diagnosis and often can give you enough information to come up with a game plan. But further characterization, including the subtype and then also immunophenotyping, these neoplastic cells would require additional tests. And this includes histopathology and then different tools to do the immunophenotyping. Immunophenotyping has become really popular and then commonly used in veterinary medicine. And it is actually requested by about 75% of the oncologists. And phenotyping is really useful, and it can have different treatment recommendations and then also different prognostic indications. And there are multiple ways to perform immunophenotyping. We can do immunohistochemistry, which will require histopathology. We can do flow cytometry, or we can do PAR or PCR for the antigen receptor rearrangement. We can do immunocytochemistry, but immunocytochemistry can be hit or miss, and it can be difficult to interpret. So I personally don't really like the immunocytochemistry. I prefer IHC or flow or PAR, but immunocytochemistry is also available. One interesting discussion that we sometimes have at Moichor is whether CBC can indicate lymphoma in a lymphoma suspect patients. We get questions from clients time to time when they have clients with a suspicion of lymphoma, whether we see the evidence of lymphoma in the blood. Unfortunately, this is not really the case for most lymphoma cases. Sometimes the neoplastic lymphocytes will go into the bloodstream and then they can be caught on CBC, and sometimes we see neoplastic lymphocytes on the blood smear. But this leukemic phase of lymphoma or stage 5 lymphoma is not really common, and it only happens in about 20% of the lymphoma cases. And another interesting misconception is that lymphocytosis may indicate lymphoproliferative disease or like lymphoma specifically, but this is also not true in most cases. Most patients with lymphoma will present with lymphopenia as opposed to lymphocytosis due to the endogenous corticosteroids, so basically the stress response. So the lymphocyte count is also not a very sensitive indicator of lymphoproliferative disease, except for lymphocytic leukemia. That's a different story. But for lymphoma, CBC is not really a useful tool to rule out or rule in the disease. So lymph node cytology, this is a very commonly performed test in veterinary medicine. And it is a rapid and also relatively non-invasive and relatively cost-efficient method to assess the lymphoid population. There are multiple case scenarios where lymph node aspirate can be recommended. Lymphadenopathy, either localized or generalized, is the most straightforward one. But sometimes when patients have certain neoplastic disease like mast cell tumor or oral or nail bed melanoma, lymph node aspirate is indicated even if there is no local lymph node enlargement. Some infectious diseases, such as the fungal disease, can show up in the lymph node as well. And sometimes veterinarians may consider aspirating lymph nodes when looking for occult diseases. For example, if the patients show up with persistent hypercalcemia that cannot be explained, maybe it is a good idea to check the lymph node and then rule out hidden lymphoma. There are many things that we can see when we do lymph node cytology. The top left figure shows the normal lymph node. So vast majority of the lymphocytes in this figure are small and mature. Lymph node can show reactivity. So when there's reactive lymphoid hyperplasia, the lymphoid population becomes heterogeneous. So we have more intermediate to large lymphocytes, and then we see many plasma cells. So the entire population becomes heterogeneous. But in reactive lymph nodes, we still see small lymphocytes as the majority of the lymphoid population. Large cell lymphoma will be a really good one for cytology in terms of final diagnosis. The large cell lymphomas will show this really monomorphic marked expansion of abnormal large immature lymphocytes. Sometimes we can see metastatic disease in the lymph node. So the bottom left figure shows neoplastic epithelial cells in the middle, surrounded by mixed and reactive lymphocytes. And the bottom middle figure, this was actually a case that I had a few years ago, and this was a lymph node aspirate from a cat, but this lymph node was almost completely effaced by this fungal yeast, the cryptococcosis. So sometimes we can catch the fungal disease in the lymph node as well. So with that, I would like to introduce our exciting new offering, which is the PathView AI-powered lymph node assessment. PathView AI-powered lymph node assessment is a rapid and AI-powered cytological assessment of the lymph node aspirates. We are going to launch this new test December 1st this year, and this test will be available in dogs and cats. And what it does is basically we developed this AI model that will look at the sample and then assess whether the samples are consistent with large cell lymphoma or not. So the type of lymphoma that is detected by this test will be the large cell lymphoma, like shown on the left. And small to intermediate cell lymphoma is not going to be a good candidate for this test because the cytological diagnosis of the small to intermediate cell lymphoma is very challenging, as we discussed earlier. And confirmation of small to intermediate cell lymphoma ultimately requires more testing, ideally histopathology, but we can do like PAR or flow. So small to intermediate cell lymphoma is not going to be a one cytology diagnosis in vast majority of cases. So the AI will look at and look for some of the morphological characteristics of large cell lymphoma, including the marked expansion of monomorphic and large immature lymphocytes. We expect them to have delicate and open chromatin and plus minus nucleoli, and we might see some mitotic figures. So this is what we're going to look for. So this AI-powered lymph node assessment, when we first launch this test, we will be monitoring the test and then making sure that all results are accurate. So at first, all the results are going to be reviewed by pathologists manually. But eventually, this test will be AI-powered 100%. So this is going to be able to offer you the rapid diagnosis, and this rapid diagnosis can happen while the patient is still at your clinic, which allows you to make immediate actions whenever necessary. And the good thing about this test is it's available all day, every day. So this will be very useful for example, emergency cases or after-hour cases, or if you are located internationally, this will be really helpful. And also, this will be a useful screening test for higher volume practices. And even after we automate this test, we will also have the AI assessment with the pathologist confirmation item that is still available. So when in doubt, or when you guys want a second set of eyes, we are always here for you. And human pathologists will review those cases when requested. So in summary, lymphoma is a spectrum of very different and very heterogeneous group of diseases, ranging from slow growing to indolent disease to rapidly growing and very aggressive disease. Small cell lymphomas can be challenging in terms of diagnosis, especially for cytology. So oftentimes it will require additional testings, including histopathology. In PathView AI, lymph node assessment will enhance efficiency, and it can also increase your confidence at your practice. And in the future, AI assessment with the pathologist confirmation will also be available. So here are the key references for my part. And with that, I would like to hand it off to Dr. Liam Cattell.
Great, thanks. Thanks, Carrie. Yeah, so hello, everybody. My name is Liam Cattell. I am the Chief Technology Officer here at Moichor, and I'm excited today to share with everyone a bit of the behind the scenes of this new large cell lymphoma test and the AI that's powering it. But before we get started, I want to talk a little bit about the diagnostic challenge that we face in the veterinary world. And Dr. Davis did a very good job of setting this up, right? Cytology is routine in the clinic. You guys run a lot of cytology tests, create a lot of cytology slides, but the diagnosis of these and using these is difficult. There is subjectivity in the cell populations and those estimates there. We saw plenty of figures in the earlier part of this talk where it really highlighted how difficult it can be to identify different kinds of cells and subsequently different kinds of lymphoma as well. What that means is it leads to time delays for specialist reviews, right? You need an expert to look at these. You need an expert who's seen a large number of cases, a large number of slides, a huge number of cells that can really help you understand what you're seeing. And there's a real scarcity of the clinical pathologists and the specialists that can do this. I would love to be able to clone our pathology team and double or triple the size. I'm sure Dr. Davis would love to do the same, and all of our customers would also love that too. But that's just not possible. There really aren't enough clinical pathologists to go around. Okay, next slide. So our solution to this is an AI-powered pipeline, and some of you on this call may be customers of ours and may have experienced our AI in other tests as well, primarily the CBC, but we also do skin and ear cytology, get those words out, AI tests too for dogs and cats. And this is an extension of our AI services. So we've developed an AI tool to assist in the analysis of canine lymph node aspirates. And as Dr. Davis said, it's designed to be fast, it's designed to be objective, and hopefully a powerful aid for diagnosis. By using AI and computational approaches, we're increasing the efficiency, right? You should be able to get rapid, reliable results. We're also providing a quantitative backing. So we're moving from many large lymphocytes seen or many white blood cells seen to being able to give you an exact number. And part of this is the real challenge of any of this AI and computational development, is sort of translating the fuzzy requirements from pathology textbooks and from the pathologist's brain and create sort of cold, hard, numerical, quantitative systems. But if you can do that, then you've standardized the assessment. And as an effect of that, you're reducing the inter-observer variability. So you will get consistent results, right? If you give this AI system the same image 5 times, it'll give you the same answer 5 times, which is maybe not always the case veterinarians and specialists. Okay, next. Yeah, so our solution to this at the moment is a three-stage pipeline, and it's mimicking the workflow of a pathologist. So step one is the assessment step. That's looking at the entire slide, finding diagnostic quality regions, and trying to assess the overall slide quality. Once we've done that, we can move into step two, which is the classification step. In this step, we're detecting and identifying all of the relevant cells in those quality regions. And then the third step is the analysis. And that's where we're taking those detections and those classifications and looking at the relative cell frequencies and overall cell numbers to generate a final diagnostic classification of, is this large cell lymphoma? Yes or no? Next. So step one is what we call the monolayer identification. This is very similar to what you would do with a CBC as well, where you're looking at the slide. You have to find regions with good staining, with good cell distribution, where things aren't too clumped or there's too many artifacts. You've got to find the good quality regions to do your subsequent analysis. So what we're looking for are regions that look like the one here on the left, and trying to avoid regions and fields in the slide that look like the image on the right, where we've got too much stain or clumping or other problems. Next. The monolayer identification, kind of like the entire pipeline, also mimics what a pathologist would do. The first part of this is scanning the entire slide, or at least the whole area that was scanned on the microscope, to find those optimal areas with minimal clumping and ideal stain. From there, we're looking at the number of those regions that we found, right? If we can't find any good regions to analyze, then we're going to flag that, and someone will have to remake the slide or rescan the slide, or have some kind of manual intervention. And the reason for this is the garbage in, garbage out component of this, right? This monolayer selection is the gatekeeper to the rest of this AI pipeline. So we have to stop the bad slides and the bad fields and the bad images at this point, because otherwise you're not going to get a reliable diagnosis at the end of it. Next slide. As part of this step one, this monolayer identification, the AI, again, like a pathologist, is using color and shape and cell density information. So we have the input slide there. We're assessing every field in that slide and assessing the color and the cells and the shape and the staining within those to produce what we call the monolayer probability map, where high probability indicates regions and fields that are good for the subsequent analysis, and low probability regions are areas that we don't want to consider for further analysis. So if your slide consists of primarily low probability regions, then we know we can't take this any further, and someone is going to have to step in and potentially remake that slide. The high probability regions, we can take those fields from those regions and do our next step of the analysis. So if you hit next, we can see here some of the fields in the high probability regions in this slide, and they look pretty good in terms of the cell staining and the cell distribution that we're seeing in there. All right, next. And just for kind of complete comparison here, Dr. Davis went through our entire training set of slides and validation set and manually marked on all of those slides the region that would be appropriate or that she would use to do her analysis. And this ground truth region here is highlighted in red. And you can see the ground truth region from the pathologist matches pretty well our high probability regions there in our monolayer map. So we know we're taking good regions for further analysis. Next. Step two is the cell detection and classification part of the pipeline. This is really the core of the AI, where the magic happens, as I put it, where the AI is meticulously detecting and cataloging every relevant cell in those good quality diagnostic areas. So it's identifying and counting small lymphocytes, large lymphocytes, lysed cells, other white blood cells, neutrophils, eosinophils, trying to identify mitotic figures in there as well to get a more complete picture of what's going on. Next. So to train this part of the pipeline, to train this AI model required thousands of manually labeled cells. So again, Dr. Davis and her team took a lot of our cytology slides that we have seen historically at Moichor and went through and painstakingly tagged the white blood cells in those smears. So I'm showing an example of one of the fields here with the small lymphocytes marked in red, large lymphocytes marked in black, lysed cells in that cyan color, and other cells all just kind of lumped together here. I'm showing with green. But you can see the pathologist and the AI prediction here look fairly similar to one another. It's kind of a fun game of spot the difference, but for the most part, they are very, very similar. If you hit next. There are definitely some differences in here that you might have spotted. The one that stood out to me in this particular field in the bottom right-hand corner where I've put those orange arrows is a slight discrepancy there where the pathologist has labeled 2 large lymphocytes that have been missed by the AI, but subsequently the AI detected and identified a cell that hadn't been tagged by the pathologist. So there's potential here as well for the AI to find things that the pathologist has missed. And if you hit next. And what we can see just from the general trend in this field is those numbers are very, very similar, right? The small lymphocytes, the pathologist detected 8, the AI detected 7. Large lymphocytes, it was 79 to 77, lysed 34 to 31, and so on. So when you're considering an entire population across an entire slide, I think being off by 1 or 2 here or there is pretty good. It's not going to change that overall distribution and overall picture when you're considering the ratio of small to large lymphocytes very much. Next slide. So just for kind of completeness, there's another slide or another field from another slide with a slightly different staining profile. Looks a bit different to the image we saw in the previous slide. And you can see here again, the agreement between the pathologist and the AI is pretty good. That general trend is being picked up again, and the numbers are, there's only small discrepancies in those numbers. Next slide. So as I said, there is good agreement between the pathologist and the AI. What I'm showing in this figure here is specifically for the large lymphocytes. On the x-axis here, that's the number of large lymphocytes that were identified by the pathologist. And on the y-axis, you have the number of large lymphocytes identified by the AI. And those blue dots, each one corresponds to a different image. The dashed red line there is the perfect line. So if the number from the pathologist exactly matches the number from the AI, they'd be on that dashed red line. And I would say they're pretty close to it, particularly because manually tagging all of these cells is a very time-consuming and tiring task. So we know there are definitely some cells that have been missed by both the pathologist and the AI. The correlation on this figure, for anyone that's interested, the R-squared is about 0.97 for this one. So there's a very, very good correlation for the large lymphocytes. If you hit next, we can expand this to kind of the other cell types that we talked about, the small lymphocytes, the lysed white blood cells, and those other white blood cells. And again, the agreement here is pretty good. Those of you with a keen eye might have spotted a couple of outliers in the small lymphocytes and the lysed white blood cells. So we hit next. There we go, highlighting those with the red circle and the cyan circle there. If you hit next again, what I wanted to show was what that outlier actually looks like, and sort of highlight a feature of the AI, right? The AI has a tendency when it's unsure to identify cells as lysed rather than trying to call it as a large lymphocyte or a small lymphocyte. As you can imagine, the boundary between those two lymphocyte types, small and large, is kind of fuzzy. A pathologist is not getting a ruler out and making exact measurements to say if something is small or something is large. They're doing this by eye. So there's a definite overlap between those two cell classes in the data that we see. So in those cases, the AI will tag those as lysed instead. What that means is they don't factor then into the ratio of large to small lymphocytes that we're looking at because it's unsure. What that also means is it adds an extra check as part of this process where we can use that number of detected lysed cells as an indicator as to whether someone should step in and have another look at this, right? If we're detecting a lot of lysed cells, we know that the AI perhaps wasn't sure, or genuinely maybe the slide does contain a lot of lysed cells and needs remaking. So we have a little bit of protection here with the way that this AI system works. Next. The final step in this pipeline is the diagnosis module. This is doing that final analysis and classification. So the module is analyzing those cell populations that were detected in the previous step. It's considering the total number of cells analyzed, the percentage of large versus small lymphocytes, and the ratio of intact to lysed cells. As I said, if we're detecting a lot of lysed cells, that's an indicator that we perhaps need some intervention here. And then based on the criteria that we have that's been drawn from historic data that we have seen, as well as input from our pathologists, it's providing a final classification. And that final classification is either images consistent with large cell lymphoma or images not consistent with large cell lymphoma. And the screenshot there on the left-hand side kind of shows you what that would look like in one of our PDF reports. So very straightforward, hopefully very clear, and very actionable in the clinic when you get those results back. If you get next. With the current validation data that we have from slides we have received from customers that have done lymph node aspirates, this system has detected lymphoma correctly in 96% of the cases. So definite room for improvement, but we're very happy with this accuracy so far. All right, next slide. So in the last few slides, I just want to kind of go over why we're using AI. I kind of alluded to it already, but really the thing here is we want to enhance the pathologist, right? This isn't a replacement for a pathologist. Dr. Davis and her team have, a huge amount of training and experience to draw on. Oftentimes as well, clinical context is really helpful when making decisions. That is, not happening for the AI when it's just looking at a single slide. So it's not a replacement, it's an enhancement. But this AI can provide objective, quantitative data to support and speed up that expert review. Right, every step of this pipeline, if you took it as an individual component, could be very helpful for a pathologist, right? If we can filter out the poor quality slides and the non-diagnostic regions from slides in step one, and we can do that for a pathologist, we're saving them time from having to do it themselves. If we can identify cells in those slides and identify that there's a large number of lysed cells or a large number of large lymphocytes, that is useful information for a pathologist when they want to start their own investigation. So every step here is helping the pathologist and speeding up that review. All right, next. So I've kind of already said it, but the key benefits of this AI pipeline, the big one is speed, right? There's rapid turnaround here. You can get quantitative results quickly. That allows for faster treatment planning. Objectivity, by its very nature, the system is quantitative. It gives reproducible cell counts. If you give it the same image over and over again, it'll give you the same cell count over and over again. That eliminates some of the inter-observer variability and subjective estimates. The thoroughness here as well, right? This AI is analyzing thousands of cells across multiple high-powered fields, and it's counting probably far more cells than you ever could or would do manually. And the final point here is accessibility, right? By integrating this with our PathView system, we're bringing specialist level analysis and support directly into the clinic. So we're making this available at the point of care. Right, next slide. So to recap what Dr. Davis said earlier, our large cell lymphoma test is launching on December 1st. It is an AI large cell lymphoma detection right now with pathologist confirmation. We know not everybody at the moment is comfortable with AI diagnoses. So we're launching this test with pathologist confirmation in the loop. So the AI will run, it will make its own decision, and it'll hand it over to a pathologist to confirm that before we return the results to you. Again, a couple of bullet points there that I borrowed from Dr. Davis, right? This is really for large cell lymphoma only. Other types of lymphomas, those small cell lymphomas, need other kinds of tests and other kinds of evaluations, histopathology or whatever it would happen to be. So this is just large cell lymphoma right now. It's for dogs and cats, and it's a single slide submission. So create one slide, scan it, send that to us, and the AI will run from there. All right, next slide. And again, finally, for me to kind of reiterate, right, this is a tool rather than a replacement. So the goal here is not to completely replace the pathologist. They have a huge wealth of knowledge and expertise that we're only scratching the surface of. But we're trying to empower every veterinarian with a tool that can provide the same level of confidence, speed, and precision as that specialist in these particular tests. All right, next slide. That's it for me. I think we're going to open it up to any questions. Yeah. Anybody? All right, cool. Well, I guess if there's no questions right now, the recording for this will be made available to everybody afterwards. We'll be sending out some more information as well about the AI lymph node assessment test and what that means and how to use it. So please be on the lookout for those. And I guess in that case, we'll give everybody a few minutes back before the top of the hour.
Thank you, everybody, for joining.
Thanks everybody for joining. Bye, everyone.
Thank you.
Thank you.